I asked this question in my Facebook group, Medicare billing for mostly cash-based PTOT SLP. And basically the question, I thought it was a pretty legitimate question, was what are we as a profession doing to bring down the cost of care? Because we see so many discussions about wanting more reimbursement, reimbursement declining, Medicare doing a 3+% cut to reimbursement. But it got me thinking like, okay, so what are we doing on the other side of that to bring down the cost of care? I know I've been a physical therapist since 2006. I've been a private practice owner since 2002. There's a lot that I've done to bring down the cost of care, not just for me personally delivering my service, like me personally as a therapist. I can absolutely deliver a better patient care experience, a better protocol for specific conditions today than I could have 10 years ago. I'm a better therapist. I'm more efficient. I can achieve certain goals more quickly. But as a practice owner, I can also leverage resources that I've built over the past 20 plus years of practice ownership. So let's take a simple example. I think everybody's going to agree with this. If we look at total knee replacement, if you guys know me for any length of time, you know my niche has kind of become total knee replacement, rehab. And so if I'm going to treat an individual following a total knee replacement, historically, if you would have caught me as a new grad, if you would have caught me in the first couple years of my clinical career, I wasn't very good. I had no experience. I had nothing to draw from. I would read the protocols, I would do the research, but ultimately it took me doing everything to achieve the outcome expected for that client. I also didn't have any resources, right? I didn't have a bankroll. I didn't have a clinic. I didn't have tools and devices. So now, 20 years in the future, I can do an evaluation, comprehensive evaluation on day number 1. I can identify some of the predictive values that I'm going to expect for this individual. I can identify some of the problems that might arise for this individual based on clinical guidelines, based on best practices. And then I could provide this individual with the resources to really achieve the outcome without as much direct one-on-one care required. You know, there are certain things they just need to do. Whether it be the prescribed exercise program, the self-mobilizations that I recommend, whether it be exposing them to certain conditions that, you know, improve proprioception, improve balance and coordination. They don't need me there. I also have resources like my gym, like my equipment, like the people on my team, so that if I could train a non-licensed individual to deliver a certain level of supervision and services that's not covered by insurance, but still beneficial to the patient, I can absolutely drive down the cost of care for an entire episode of total knee replacement. Now, the reality is if we don't embrace this move toward increased efficiency, we see what's happening. I also have a large Facebook group of over 12,000 members that have had total knee replacements. It's called the Total Knee Replacement Support Group for Kind People. And I've posted questions in that group like, how many of you have been told not to do physical therapy after your total knee replacement? And there's a good number of individuals that have surgeons that have told them either they don't need physical therapy after a knee replacement, or explicitly they've said, do not get physical therapy after your knee replacement. So if we don't embrace this move toward increased efficiency, increased effectiveness, increased efficacy, it's just going to be done for us. And what that's going to look like is it's going to eliminate us from the equation. Now, I'm the first one to raise my hand and be like, hey, you probably don't need the stuff that we've done for the last 20 years. But you absolutely should have a physical therapy evaluation. You absolutely should have access to a physical therapist to answer your questions, to look at your incisions, to help guide you along the process. It doesn't need to be 3 times a week for 18 sessions or 24 sessions or 36 sessions, but it should be something. So I think if we can control the narrative, we can bring our expertise to the conversation, we can remain a relevant component of what happens to the future of physical therapy and reimbursement. But if we put our heads in the sand and we ignore the move toward efficiency, I think we're just going to be taken out of the equation.